In this video, I will continue to review the autopsy chapter of Essential Forensic Medicine by Narayan Reddy and Murthy. So in this video, we will discuss air embolism. If air embolism is suspected, the head should be opened first and the surface vessel of brain examined for gas bubble, which must be prominent and definite, but not segmental break of blood in the vessel, pulling the sternum and rib to avoid the creating negative pressure in the tissue, which may result in aspiration of air into the vessels. Air embolism can be demonstrated by, first, before handling the thoracic organ, the pericardium is opened and the heart is lifted upward and the apex is cut with a knife. The left ventricle is filled with frothy blood if air is present in sufficient quantity to cause death. The second way is if the right ventricle contains air, the heart will float in water. Third method is This is another method of demonstrating air embolism by cutting the pericardium anteriorly and grasping the edge with hemostat in each side. The pericardial sac is filled with water and the right heart is punctured with a scalpel and twisted a few times. Bubble of air will escape if air is present. Fourth method is a wide bore needle attached to 50 ml syringe filled with water is inserted into right ventricle. If air is present, it will bubble out through the water. Fifth method is air in inferior vena cava can be demonstrated by puncturing it under water and looking for escape of bubble of gas. Sixth method is chest X-ray, and seventh method of detection of air embolism is pyrogallol test. In pyrogallol test, 4 ml of 2% freshly prepared pyrogallol solution is collected into two 10 ml syringes. To the first syringe, 4 drops of 0.5 molar sodium hydroxide solution is added. Gas is aspirated from the right side of heart and the needle is removed and replaced with a stopper. And then syringe is shaken. If air is present, the mixture turns brown. In second syringe, some air is introduced and test repeated as control. The solution should turn brown. This test helps to differentiate gas present in the heart from gas formed due to decomposition. If fat embolism is suspected, the pulmonary artery should be dissected under the water and escape of fat droplet noted. Next topic is method of removal of organ in autopsy. The first method is Virchow technique. In Virchow technique, individual organs are removed one by one. Cranial cavity is exposed first and then followed by thoracic cavity, cervical and abdominal organ. A spinal cord is removed from back. In this, the anatomico-pathologic relations are not preserved. So second method of removal of organ is Rokitansky technique. It involves in situ dissection in part combined with in block removal. It is preferred choice in patients with highly transmissible disease such as HIV and hepatitis B. Third method is Latiol's technique. In Latiol's technique, cervical, thoracic and abdominal and pelvic organs are removed in masses and dissected as organ block. It has the advantage of leaving all attachment intact. Fourth method is Ghone's technique, where cervical, thoracic, abdominal organ and urogenital system are removed as block. Neuronal system is removed as another block. The greater omentum lying across the small intestine is pushed upward across the liver. The upper part of a small intestine is grasped into the left ventricle and followed upward until it disappears retroperitoneally to become a duodenum. Then the mesentery is penetrated with a point of knife at duodenojejunal flexure and two pieces of string are passed through the hole. Then they are brought upward and tied separately and tightly around the gut. Now the gut is divided between these two ligatures. The coils of intestine are pulled forward by the left hand and mesentery is cut close to the mesenteric border of gut until the ileocecal valve is reached. The cecum is mobilized and the ascending colon pulled forward and medially by left hand, and its attachment with the posterior abdominal wall are cut with the knife up to the hepatic flexure. The omentum is pulled down and transverse mesocolon is cut through with knife until the splenic flexure is reached. Then the descending colon is freed in similar manner until the sigmoid is also free. The upper part of rectum is mobilized and cut through between two ligatures below the brim of pelvis. The whole of a small and large intestine is removed from the abdominal cavity. Next, the axillary bundles which lie behind the clavicle and first rib are cut by passing the knife upward on each side of thoracic cavity into the neck. Pleural adhesion between the lung and chest wall, if any, should be cleared by finger or knife, and slip the finger of both hands between the lateral portion of one lung and inner side of chest wall. The left hand work up to the apex, the right down to the base, and they meet at hilum. The neck structure are grasped in masses in left hand and pulled downward, cutting the structure on the front of a spinal column to the level of diaphragm. After this, the thoracic organs are put back into the thorax. The stomach and spleen are pulled medially by left hand, and diaphragm is removed by cutting through its attachment to the rib and both sides. The thoracic organs are pulled down by gentle traction on the neck structure, and the cruciate ligament which attaches the diaphragm to the spine is cut, and the organs are then put back into the thorax. The spleen and tail of pancreas. The spleen and tail of pancreas are held in left hand, and dissection is carried behind them to midline. The diaphragmatic surface of a spleen is held in palm, and vessels at the hilum are cut after they have been inspected. The liver is pulled medially, and the knife is passed behind it to free it from attachment. And the peritoneum and fat are cut just outside the lateral border of kidney, which is then grasped in the left hand and mobilized by dissection behind it to midline, freeing it from anterior surface of iliopsoas muscle. The ureter is identified and free all the way down to its entry to bladder. Both kidney are then taken in left hand, and knife is carried down the midline behind the aorta to pelvis. The knife is passed around side wall of pelvis, dividing the lateral attachment of bladder, each side of pelvis being dissected downward to midline. The anterior surface of bladder is free with finger from the pubis bone. The femoral vessels are cut at the level of brim of pelvis. The contents are pulled upward, and the urethra and vagina divided as low as possible. The whole block of thoracic and abdominal organs are pulled forward and removed in mass. The atlanto-occipital joint should be examined by moving the head of a spine and to note any fracture or dislocation. Examine the cervical spine for fracture, the so-called undertaker's fracture. Undertaker's fracture is caused due to head falling backward forcibly after death, which tear open one of the intravertebral discs, usually around C6 to C7, due to which the subluxation of lower cervical spine occur, and the thoracic and lower spine should be examined by pushing a hand under the body to raise up the spine forward, which show any abnormal movement of at the site of fracture. The cervical spine can be tested by manual manipulation. To detect fracture of sacroiliac joint or of pubic bone, the pelvis should be squeezed from side to side by pressure on each iliac crest. Now we will discuss examination of organ. The in-mass chest and abdominal organ are kept on wooden board with posterior surface upward and tongue facing the operator. Description of an organ. A description of organ system should be limited to clear, concise, objective description of shape, color, and consistency, and the presence or absence of any lesion other than those systemically described under trauma. The microscope description may be limited to positive finding. The pathologist should indicate those tissue he had examined and a number of sections he taken in any one tissue. So first description of any organ is size. Size is measured by tape. In the liver, blunting of inferior border point to enlargement while sharpness to atrophy. Usually dense capsule is in favor of enlargement and loose capsule with laxness. A straight course of superficial vessels, as on heart, show increased size, while under tortuosity means decreased size. Second description is shape. So note the shape for any departure from normal. Third, surface. Most organs have delicate, smooth, glistening, transparent capsule of serosa. Look for any thickening, roughness or dullness or opacity. Consistency. So the softness or firmness as measured by pressure of finger. Fifth is cohesion. Cohesion is the strength within the tissue that hold it together. It is judged by resistance of cut surface to tearing, pressure or pulling. An organ with reduced cohesion is friable, while when it is increased, the tissue seems to be tough or leathery. If a small tooth forceps bite into a testis, it should put away thread composed of tubules if it is normal. Sixth is cut surface. Color. Every organ except brain is basically some shade of grey, but this is altered by red contributed by its blood supply. Other color can also be added by jaundice or fatty infiltration, which will be yellow color. Lipofuscin or hemosiderin, which is brown color. Malarial pigment, grey brown. Anemia causes pallor, while congestion add a blue tinge. Structure. This is a factor of particular organ. Example, cortex and medulla in the kidney. In disease, these may become indistinct or greatly exaggerated. Oral cavity. Examination of organs should be done systemically from above downwards so that nothing is missed. Examine the tongue for any disease or injury, especially bite marks, which are usually seen along the side and less commonly at the tip. A small hemorrhage is seen under intact mucosa in bite mark. Serial incisions should be made through the tongue for presence of bruise. The pharynx, epiglottis, glottis should be examined, especially for foreign objects. The condition of tonsils should be noted. Next, structures. A large blunt pointed scissor is used to cut open the esophagus from the posterior surface up to the cardiac end of stomach. The lower end often show a postmortem erosion due to regurgitation of gastric juice through the relaxed cardiac sphincter. Note for the presence of any capsule, tablet, powder, etc., which should be preserved. A special precaution should be taken in case of varices. If esophagus is cut at the lower end, blood will drain from varices, which would then collapse and may be missed. When death occurs from the rupture of esophageal varices, the break should be demonstrated. A blunt-ended fine probe is helpful in cases where the milking of vein does not force a little blood through the tear. Injection of saline or colored fluid into the varix is useful to find the leakage from the tear. The larynx. Larynx lie opposite to third to sixth cervical vertebra in the adult male and little higher in adult female and children. Laryngeal prominence is 2 to 5 cm below the hyoid bone when chin is held up. Larynx, trachea and bronchi are examined by cutting them open from the posterior surface. The presence of blood, mucus, foreign body, vomited matter, tumor, inflammation, mucopus, etc. in them should be noted, and the thyroid is removed and examined. Sections are made in both lateral lobes along their longest diameter. The parathyroid examined. The carotid artery must be examined for presence of thrombosis, particular bifurcation near the skull. The hyoid bone, thyroid and cricoid cartilage are examined for any fracture or contusions. Jaw examination. If rigor is present, to remove mandible, autopsy incision is extended into the neck, V-shaped, and the skin of lower part of the face is Dissected. The masseter and temporalis muscle are divided above their insertion into the mandible to allow the jaw to become while the maxilla, plate and inferior part of the facial skeleton is removed by sawing horizontally across the maxilla at the level of lower margin of nasal aperture, taking care to saw above tooth roots. Next organ is lung. Place the lung with anterior surface uppermost and open the pulmonary artery and continue into the lung tissue as far as a small seizure will allow one to go. Look for thromboemboli and atherosclerosis. Trace the course of pulmonary vein into the lung, looking for evidence of thrombi. An antemortem embolus may sometimes be coiled and when straightened out resemble a cast of vessel from which thrombus originated. Usually in the lung, there may be side branches, but it does not fit the vessel in the lung. Massive pulmonary emboli completely block either the main trunk of the pulmonary artery or impact in one of the major pulmonary vessels, more commonly in the right side, and is always fatal. To separate the long bladed knife is placed blunt edge upward under the hilum of each lung and turn around so that sharp edge is upward. Then, with a short sewing motion, the hilum is completely cut through and the lung is held on upper surface by the left hand or by interposed sponge, an organ cut across from apex to base with large brain light, held parallel to the board. This produces an anterior-posterior slice of the lung. The lung are examined for consolidation, edema, emphysema, atelectasis, congestion, tardive spot, emboli, tumor, and infarction. The smaller bronchi are examined for mucosal thickening, infection, and blockage. The smaller pulmonary arteries are examined for thrombosis and embolism. For fixation of lung, a cannula is held or tied into the bronchus and 10% formal saline is perfused through the tube from a reservoir held 1 meter above the lung. The lung is then put in formalin solution. Next organ which will examine is aorta. The seizure is passed into the iliac vessel and whole length of aorta is cut on its posterior surface around the arc up to aortic valve. Note for any chronic aortitis with plaque formation which obstruct the mouth of coronary artery. Next organ which will examine is heart. Remove the heart with great vessels attached at least 1 centimeter beyond the pericardial fold. Examining the pericardium, while heart is still in situ for adhesion. Pericarditis, discoloration of underlying infarct, aneurysm, injury and any fluid or blood. Open with inverted T-shaped incision. Measure height from the base of aorta to apex and width at the level of valvular region and circumference 1 centimeter below the arteriovenous sulcus. Examine the surface for any visible fibrosis or recent infarct. The pulmonary arteries should be palpated before they are cut for presence of thrombus or embolus. If thrombus is felt, right ventricle and pulmonary trunk are open in situ and size and extent of thrombus noted. The size vary from clot to massive coiled thick structure. In pulmonary trunk, the larger one will be saddle-shaped, bifurcating into the pulmonary artery, and they are pink in color and firmly adherent to vessel wall. Postmortem clot are soft, friable, and yellow or red in color. Superior and inferior vena cava should be examined for presence of thrombi and emboli. The heart is held at the apex and lifted upward, and pulmonary vessels, superior and inferior vena cava and ascending aorta are cut as far away as possible from the base of heart. The isolated heart is studied as follows. It is open in the direction of flow of blood. This is known as inflow and outflow method with enterotome. The right atrium is cut between the opening of superior and inferior vena cava, and a small secondary incision is made to open the auricular appendages to detect the thrombi. While opening the right ventricle, The lateral margin of right ventricle faces the dissector, the aorta being directed toward him, and the enterotom introduced into the right atrium, cut through the tricuspid orifice, and open the right ventricle along the margin. The circumference of an intact valve of heart can be measured by inserting specially made graduated cones marked at various levels with the circumference after opening the atrium. To demonstrate the competence of pulmonary valve, the heart is held in palm of the hand so that pulmonary valve is horizontal and neither collapsed nor stretched. A gentle stream of water is directed onto the valve, and after the blood is washed away, it can be observed how well cusp come into the position and whether water leak into already open ventricle or not. The competence of tricuspid and mitral valve can't be satisfactorily tested postmortem. In opening the pulmonary valve, the heart is placed so that apex is directed toward the examiner. The enterotom is introduced into the right ventricle close to apex, and the conus pulmonalis and pulmonary valve are cut about 10 mm to right of and parallel to intraventricular septum in anterior wall of right ventricle. The interventricular septum is identified by anterior descending branch of coronary vessel crossing down the epicardium. The incision should be extended into pulmonary trunk and left pulmonary artery. Note whether the content of right ventricle and auricle are fluid blood, current jelly clot or chicken flat clot. The left atrium is cut between the opening of pulmonary vein. Then the left atrium is cut along its lateral wall, and this incision extends through the mitral orifice and passes along lateral margin of left ventricle up to the apex. The circumference of mitral valve should be measured, and the next incision extended from apex along the intervertebral ventricular septum into the aorta. Opening of aortic valve. The water competency of the aortic valve can be tested after cutting the aorta transversely. Both auricular appendage should be examined for presence of thrombi. Examine interarterial septum and for patency of foramen ovale. Examine caudate tendon, papillary muscles for infarction. Adherence to each other or rupture and chamber for any visible fibrosis or recent infarct. The heart should be weighed after the blood clot in the cavity are removed, and measurement of circumference of valve and thickness of right and left ventricle should be taken. The muscle of right and left ventricle is incised in a plane parallel to epicardium and endocardial surface, which reveal infarction and fibrosis most clearly. In death due to ventricular fibrillation, heart is flabby. Coronary arteries. So the anatomy of coronary arteries varies considerably. Usually there is short main trunk of left coronary artery which soon bifurcate into the circumflex branch and anterior descending branch. Ostia of coronary artery should be examined for patency of lumen, thrombus and any narrowing. The coronary artery are examined before opening the heart by making serial cross section along the entire course of major vessels, about 2 to 3 mm apart using a scalpel. This method demonstrates narrowing, percentage stenosis of the vessel and any antemortem thrombus in lumen without danger of dislodging it. The coronary should not be opened by passing a scissor through them from the ostia, as they have crossing and cutting action and produce so much distortion that any thrombus is obscured, and also the thrombus may be pushed along with the point of scissor. The most common site of thrombus in 1 centimeter away from the origin of left coronary artery. The anterior descending branch of left coronary artery is cut downward along the front of septum, then circumflex branch on the opposite side of mitral valve. The right coronary artery is followed from the aorta to cut near pulmonary valve and then above the tricuspid valve. The presence of acute coronary lesion, example plaque rupture, plaque hemorrhage or thrombus should be noted. Calcified coronary vessel that can't be cut with a scalpel should be stripped of the heart and decalcified at least 24 hours before cutting. Subendocardial hemorrhage. The hemorrhage are seen in left ventricles, on the upper part of left side of intraventricular septum and on the opposing papillary muscle and adjacent columnae carne. The hemorrhages are flame-shaped, confluent, and tend to occur in one continuous slit rather than patches. When the bleeding is severe, it may raise the endocardium into the flat blister. The mechanism of production is obscure. There are non-specific findings and are seen first after sudden severe hypotension due to severe loss of blood and from shock. Second is after intracranial damage such as head injury, cerebral edema, surgical craniotomy or tumor. Third one is death from ectopic pregnancy, rupture uterus, antepartum or postpartum hemorrhage, abortion. Fourth cause may be various type of poisoning, especially arsenic poisoning. Here in figure we can see epicardial hemorrhage, and here is subendocardial hemorrhage on interventricular septum. Antemortem thrombi. Antemortem thrombi are dark red, film but friable, dry, pale, granular, adherent to vessel wall, and on section show alternate layer of platelet and fibrin, coralline platelet thrombus. Dark line are composed of red cell and network of fine white line of fibrin. Older thrombus is grayish red and varies in color from place to place. When lung is sliced, emboli is slightly projected above the surface. The postmortem thrombus is dark red, glistening, soft jelly-like and very friable. Agonal thrombi. In case of person dying slowly with circulatory failure, a film, stringy, tough, pale yellow thrombus form in cavity usually on the right side of heart. The process begins in arterial appendages in apex of ventricle or in the angle of ventricular surface of tricuspid valve. It extends and fills the right auricle and ventricle and spread into the pulmonary artery and its branches like tree-like cast. In the left ventricle, agonal thrombi are not so big. Postmortem clot. Two types of postmortem clot are seen. First, when blood clot rapidly. Soft, lumpy, uniformly dark red, slippery, moist clot is produced that is red current jelly. Second clot, when red cells sediment before blood coagulate and the red cell produce a clot similar to first type. Above this, a pale or bright yellow layer of serum and fibrin is seen, that is known as chicken fat. The fibrin clot may be soft or jelly-like but is elastic when the amount of fibrin is greater. Usually a mixture of two types of clot is seen. Postmortem clot are moist, smooth, shiny, rubbery, homogeneous, loosely or not at all attached to underlying wall, and there are no fine white line of fibrin, that is known as stria of Jahn. When pulled out of vessels, it forms the cast of branches. When the lung is sliced, clot does not pour out of the small vessels. Postmortem fibrinous clot in heart are known as cardiac polyp. Postmortem fluidity of the blood. So shortly after the death, the blood is usually fluid, and when it is removed from the body, it undergoes spontaneous coagulation. And if the autopsy is done a few hours after the death, blood may be partially clotted and partially fluid. Uncoagulable fluid blood is normally present in lymph vessel and often in the heart of any healthy person who dies suddenly from any cause. It does not give any indication of cause of death. In most deaths from asphyxia, the blood is fluid and incoagulable. The postmortem fluidity of blood is due to presence of fibrinolysin liberated from the vascular endothelium. Fibrinolysin activation occurs due to release of plasminogen activator through the receptor on the vascular wall for various vasoactive material that increases during agonal period. Fibrinolysin is also activated by leakage of plasminogen activator due to increased permeability and to degeneration and to necrosis of cell membrane. As a result of excessive acidosis after death, it is considered that lysine is adsorbed on the thrombi and released into the solution when fibrin is lysed. Under certain conditions, the fibrinolysin may be so active that fibrin is destroyed as rapidly as it is produced, and postmortem clot never develop in vessel. In other cases, thrombi are formed, but they undergo lysis. In death associated with infection and cachexia and slow natural death, Fibrinolysin may fail to develop an abundant clot are seen in heart and in limb vessel. The concentration of circulating fibrinolysin is more in healthy person, which is further increased during exercise and also due to emotional stress. Therefore, blood is fluid in young person dying of unnatural cause. Unclotted blood. In sudden death, the clot are greatly reduced in amount and the blood remains fluid in certain cases of septicemia, in severe poisoning, in rapid death from asphyxia with a large dosage of anticoagulant, in hypofibrinogenemia due to amniotic fluid embolism, retain abortion, and puerperal sepsis. Puerperal sepsis. So I will end this video here. We will continue in next video. Thank you for watching.